So it's important for all dermatologists to understand hair care products, the ingredients in those products, and know how to recognize and differentiate natural versus processed versus synthetic hair. This will ensure culturally competent interactions with our patients. And these are patients who often assume that you're not knowledgeable about their hair. If your hair is different from theirs, they'll just assume you don't know anything about it.
Dr. Lynn McKinley-Grant is president of the Skin of Color Society. In this episode of Dermatology Weekly, she talks with Dr. Susan Taylor about hair care products that dermatologists can use for African American women, taking care of their hair and to manage dermatologic conditions. Welcome to episode 60 of Dermatology Weekly, where we bring you the latest in dermatology news followed by peer-to-peer conversations with clinical and research experts in the field of dermatology. I'm the voice of MDedge Podcast's Nick Andrews. This week we have a special edition of the news segment. I will be welcoming the hosts of the popular dermatology podcast, Dermasphere, Dr. Luke Johnson and Dr. Michelle Tarbox. And don't forget, we love to hear from our listeners. You can email the show at podcast@mdedge.com, or you can interact with us on Twitter at MDedgeDerm. You can find the links to those in the show notes. I'm joined by two clinicians and two fellow podcasters, and which is pretty exciting. We met virtually a while ago, and we've been trying to do this for a while, so I would just say welcome to the program, Dr. Johnson, Dr. Tarbox.
Hi, thank you for having us.
Yeah, of course. So we wanted to talk to you because you are podcasters who are not in the same geographic place, which is really fun. So you have been, I guess, Zoom or Skype extraordinaires for a while now. So just talk about how the show started and talk about your different experiences trying to put some stuff together.
So the podcast that we co-host is called Dermasphere, D-E-R-M-A, Sphere. And the purpose is to update people practicing clinical dermatology about some of the latest research that's coming out in our field so that they can hopefully spend more time taking care of patients and less time having to comb through journal articles to find what they think is most important. Comes out every couple weeks, and we've been going on for almost a year now.
And how has your focus been? We know that recently, as we record this in late April and early spring of 2020, that COVID-19 is all anyone can talk about. And there's on one hand, you've got the virus and the subsequent disease, but on the other hand, many different specialties have to adapt. We know that dermatology has been a specialty that's been sort of on the forefront of telemedicine, at least with imagery of lesions, et cetera. But how has treating derm patients gone? Will you give me your experience with Dr. Tarbox in Texas, and then we'll talk to Dr. Johnson about what's going on in Utah.
Yeah, absolutely. So we have had a big shakeup to the way that we usually take care of patients. As you know, dermatology is really a hands and eyes on specialty, and the ability to really carefully examine your patients is pretty important with that. Now, fortunately, at my institution in Texas Tech, we've had a long-running telemedicine program to serve remote areas of Texas as well as the prison system. And so we're fairly experienced in that format. However, it is still a little bit different in this time of COVID because we don't have an operator on the other side like we would in our traditional telemedicine experience. So we have learned quickly how to take care of a lot of patients through telemedicine, mostly using Zoom teleconferencing with protected links. And we've been able to extend care to a large number of our patients, but we still have to have some urgent inpatient, like in-person slots for things that really need to be managed with a face-to-face encounter.
Michelle, what percentage of your normal patient population are you guys seeing, do you think?
By telemedicine or in person?
Just all comers.
It's definitely less than normal because volume is harder to manage in terms of onboarding the patients. You would think a digital visit might take less time, but our processes are so well adapted to see people in person. And I find that there's also a lot more time devoted to communication when you're doing telemedicine because the patients, for one reason or another, might be a little bit distracted. They seem to take a little bit longer to understand the instructions sometimes. And so we've actually found one good way to move forward in the telemedicine visit is to actually send a follow-up short document to the patients by email to summarize their plan of care, similar to what you might write out at the end of an in-person visit.
But this has less chance of being thrown in a physical wastebasket anyway.
I want to talk to you guys about something that you discussed on a recent episode, which is two studies specifically with lesions in children with COVID, which is something that came out of Italy, and then one of the hot button issues across all of medicine, which is PPE, and that's a Chinese study that you discussed on a recent episode as well. So just talk to me about your take on those two studies as it relates to dermatology.
Well, when it comes to the acral lesions, I'm really impressed with the dermatology community and how it has come together across countries, across different interfaces, social media networks to help cultivate a very urgently needed set of knowledge about what the cutaneous manifestations of this viral infection might be. And as we start to understand that a lot of its pathology comes from microthrombotic events, of course, it makes sense that we're going to see some of these occur in the skin. And I think that it's been important in the care of a lot of patients to recognize these symptoms early on.
So this case report out of Italy was a child, I think they were 8 or 9 years old, who was basically healthy but had a fever and developed these pernio-like lesions on the toes that were painful and itchy and sort of ran their course over 2 weeks. And his family members at home had COVID. He wasn't able to be tested because of the circumstances at the time, but the presumption is that it was probably due to the same thing. And recently there was another article published with 2 cases out of the Middle East in young adults in their 20s and 30s who had similar findings.
One other thing that we're finding at MDedge is the relationship between mentors and mentees, as well as educators and pupils, as it relates to students, residents, fellows, and young attendings. How has this impacted your ability to be educated and be educators?
You know, it's definitely shaken some things up. I've found that in an effort to sort of help maintain normalcy, my natural instinct has been to reach out with more educational opportunities to my residents. And so we're having a lot of Zoom conferences to do clinical pathologic correlation because our DermPath caseload is down, of course. So I want to make sure that that dermatopathology education continues. We've actually been able to collaborate with doctors at other institutions. I used to practice in St. Louis University for 3 years after I graduated residency. And so I have some fantastic colleagues there. And we've been doing Zoom lecture exchanges to help facilitate the education of our different resident populations, and certainly trying to keep tabs on patients that and residents as they're going through their educational experience in this sort of unusual territory. We've even had in our residency the experience of one of our own residents getting sick from the virus, and you know it really hits close to home when you have somebody that you care about that's sick with this thing. And so checking in regularly with those people to make sure that they have all of the things that they need, you know, not just that they're mentally well and that they feel supported and cared about, but also, do you need medicine? Do you need, you know, we live in the same city. Can I bring you something that you might need? I think that it's a time when mentorship has to change formats a little, but there's also opportunity to lead through this time of strife. And the need for leadership is greater when we have this kind of crisis.
And I tell everybody to listen to dermatology podcasts.
Thank you for that. We appreciate that as well, of course. I was in a meeting at ASCO in 2016 where there were some novel ideas about how to use Skype and FaceTime at the time to get, I guess, very early discussions between patients who thought they had a skin cancer or a melanoma and their dermatologist or their primary care provider, and everybody was really excited. However, it's one of those things where I always say that medicine, it's things need to be pushed through. It's about a decade behind where popular culture is. I've been using Zoom for years, and now that we have this crisis to respond to, it seems like everything has to be jump-started. You have to adapt. Do you two see this becoming not the, I guess, standard operating procedure, but do you think that when we make it through all of this, that Zoom and FaceTime and Blue Jeans, et cetera, will be a bigger part of dermatology practice?
Well, there's definitely a space and a need for the ability to engage with patients who might have less of an easy time coming in person. That touches us really, you know, at our heart here in West Texas, because we're in an area that we're what we call the hub city here in Lubbock. So we have our population center of about 250,000 here in Lubbock, but surrounding this are lots of all these small communities, and we have a large catchment area, and some of our patients travel up to 3 hours to come see us. Some of our patients we've taken care of over telemedicine in the past several weeks have expressed how much simpler this is for them and their family. A lot of them have low income and might have difficulty with this kind of travel. It might require time off from a job that doesn't give a lot of personal or family leave. And so for a lot of these patients, some of them have asked if they can follow up with us by telemedicine. So I think that you're absolutely right that sometimes crisis is the mother of invention, and necessity kind of pushes us towards a place where we might be actually able to better take care of some of our patients. Certainly there are kinds of visits that aren't well adapted for telemedicine. If you're really doing a skin check on a patient with a high risk of making bad skin cancer, I need to be able to see that patient in person. But when you're managing something like eczema or acne, where it's something that's a little bit more of a global problem and where the granular level of detail that you might need in a skin exam isn't as necessary, I think that it could be a cost and time savings for the patient and could potentially take some of the burden off of some of our lower income families.
I think that dermatology in general was slowly oozing toward the use of telemedicine judiciously before this. One of the silver linings is that this crisis will give telemedicine a shot in the arm, and all the patients will discover that there's parts of it that they really like, and clinicians will feel the same, and then there will be pressure on insurers to reimburse for it, which has been the major stopping block up until now.
Yeah, and that makes total sense as well, because they're going to have to respond to the crisis in their own way. And I know both of you have similar challenges when it comes to being in a population center and then driving 20, 30, 40 minutes outside of town. All of a sudden it becomes really rural really quickly. I'm, of course, we talked about this on the post-call podcast when Dr. Johnson was a guest. Grew up in your neck of the woods, in one of those catchnet areas about 2 hours outside in southwest Wyoming, so very familiar with where you're from. So this is episode 60 of Dermatology Weekly, and coming up after the break, Dr. Lynn McKinley-Grant, who is the president of the Skin of Color Society, is here to talk about something that is really, I guess, not something that I would have thought was part of what could happen with COVID-19, but very important. I just want to get your guys' thoughts on that before we get to break. And that is hair care products and how it's affecting women in the African-American community. And it's extremely something that is a bigger issue as we get further and further into COVID-19.
Yeah, we actually had an article that we reviewed earlier on in our podcast series about how there are some chemical differences in the hair care products that are marketed towards women of color versus the general population, and how there might actually be more hormone modifying chemicals that potentially could influence the risk of endocrine disruption in some of these products that are marketed more exclusively to women of color. Also, certain products that are used, such as relaxers and things like that, that might cause injury to the hair and potentially predispose patients to developing inflammatory alopecias. And I do think that that is an area of disparity that needs to be addressed, and that clarity in packaging rules need to be put into place to protect consumers.
On a lighter note, one of my extended family members recently mentioned that she's not able to go buy her normal hair dye, and so she's going to be looking completely different when all this is over. No one will recognize us.
Yeah, I suppose that is something to think about. It's a good time to go incognito. Well, they are Dr. Johnson and Dr. Tarbox. They host Dermasphere. How often is that episode or the show published? I believe every couple of weeks. Is that right?
Every 2 weeks, with some bonus episodes these days, because we think people have more time to sit around and listen to podcasts. And
we were finding that is true, that people are listening a little longer, which is definitely exciting. You can find a link to Dermasphere in the show notes, and I think it would be nice to have you guys on every now and then to break down things exactly like this, if that's something that you'd be interested in.
Absolutely.
All right, stick around. Coming up after this, the president of the Skin of Color Society, Dr. Lynn McKinley-Grant, will join us for Peer to Peer. Welcome back to episode 60 of Dermatology Weekly. It's time now for Peer to Peer. Please welcome our guest speaker this week, Dr. Susan Taylor.
Well, today we're here to discuss with Dr. Susan Taylor her very recent and timely article entitled Hair Care Products Used by Women of African Descent, and a review of the ingredients. And this article was actually written and accepted by CUTA several months before the advent of the COVID-19 pandemic. And as the virus is spreading and closing many non-essential businesses, including hair salons and barbershops, and people are sheltering in place, women of African descent now have to take care of their hair at home whether it's natural or processed. As a dermatologist, this article is going to be very important to hear about because of the ingredients and the need to be able to discuss with your patients what and how they should be taking care of their hair and understanding the products that you might be able to recommend or understanding the products that they're using and why they're using that. So, Dr. Taylor, I'd like to start with the first question of why is it so important that dermatologists be aware of common hair and scalp beliefs, misconceptions of care, and product use to ensure culturally competent patient interactions and treatment? Well, so Dr. McKinley-Grant, it's just that. So it's important for all dermatologists to understand hair care products, the ingredients in those products, and know how to recognize and differentiate natural versus processed versus synthetic hair. This will ensure culturally competent interactions with our patients. And these are patients who often assume that you're not knowledgeable about their hair. If your hair is different from theirs, they'll just assume you don't know anything about it. Also, the knowledge will inform the dermatologist regarding the diagnosis of hair breakage as well as inform treatment recommendations. And that's so true, and it develops such a confidence of the patients and the patient-doctor relationship. You discussed in the article 4 steps in taking care of hair of African descent, which includes washing the hair, conditioning it, whether leaving it in or the conditioner in or washing it out, detanglers, and styling the hair. And the article is very well written, as usual, in a very reader-friendly reference style where people could refer back to it as they discuss hair care products with their patients. But I was wondering if you could review the products and just kind of the broad categories. Sure. So I think the first thing that's important for all dermatologists is to understand what kind of hair their patient has. So we divide that into natural hair, processed hair, and synthetic hair. So natural hair is hair that's not been altered with chemical treatments, and these chemical treatments break and reform disulfide bonds in the hair. So that hair is usually very curly or tightly coiled. Processed hair is hair that's chemically treated with a variety of straighteners. Now, synthetic hair, on the other hand, is made of plastic or acrylic fibers, and it is used for hair weaves and hair extensions with braids. It's also important to note that with the synthetic plastic hair, it can be flammable and it can cause a contact dermatitis. So I think that's important. So to really get to the heart of your question, it is important for all women to shampoo, to condition, and then everyone is going to detangle their hair and style their hair. So what we did was we did a literature search initially and had many keywords, including natural hair, relaxed or permed hair, and we came up with or identified about 80 different products. We then went to a couple beauty supply stores, a Walmart, and from that selected 57 products, which we really honed in on the ingredients. So from there, looking at the ingredient list and then looking at which products patients used who had natural hair versus chemically treated hair, we came up with a list of suggested shampoos, conditioners, leave-in and wash-out conditioners, detanglers, moisturizers, etc. I think the only way you can really learn about this is to name brand names. We don't usually do that in dermatology, but we thought it was very important in the article that dermatologists and primary care physicians be able to refer to these specific brands, and then they can discuss it with their patients. I always ask my patients, what products do you use? to shampoo and condition, etc. And often you will hear certain products over and over again, and you'll familiarize yourself with it and then go look up the ingredients. Now, for shampoos, there are a whole host of shampoos, some that are geared towards the African American community and others to the general community. So overall, in regard to shampoos, some are more harsh than others, meaning they remove more of the sebum from the scalp and the hair, leaving the hair very dried out. So the sodium lauryl sulfate containing shampoos are the ones with the most harshest detergents. So for our skin of color patients, our African American patients, we suggest shampoos that contain sodium lauryl sulfate, which is a much milder detergent to clean the hair, and it helps to leave the hair moisturized. So, for example, there's a Pantene product called Pro-V, a truly relaxed hair moisturizing shampoo that can work very well for chemically treated hair. For natural hair, Carol's Daughter is a brand that's very popular. There's a Black Vanilla Moisture and Shine shampoo. Now, with this shampoo, it contains cationic surfactants. Now, this helps to clean the hair, but it also helps to maintain the curl pattern of the hair, and that's very important for natural hair. So those are but two of the shampoos that, based upon the ingredients, we recommend.
That's very helpful. I wanted to add an example of where dermatologists will need to know these things, but I had a friend who, she goes to a hairstylist, every 2 weeks. She's a public figure, and she has to, every hair has to be in place. But with the COVID-19, she's been home working and doing her own hair, and she's decided to go natural. So she sent me a picture of 3 jars, the front and the back, with all the ingredients, and they were all styling gels, and she needed to know which one to use first. So there was a gel, there was a cream, there was another moisturizing something. So the products that she suggested I really wasn't that familiar with, so your article was very helpful. And I connected her with a hairstylist who is working with her. There are several stylists who are working with people, online and have hair appointments without actually seeing them. So the hairstylist can be a resource also for the dermatologist, even though we really need to have a basic understanding. I agree with you about that.
So with COVID-19, many women are at home, me included, and it's important for women to understand that they have to continue to groom their hair. Just because no one sees you doesn't mean that you don't regularly shampoo and condition as well as comb and style your hair. Now, I personally think this is a great time to minimize what you do to your hair in regard to heat from blow dryers and flat irons and curling irons. I also think it's a great time, if you have a weave or braids and extensions, to take them out, to really give your hair a rest. And it's an optimum time to really concentrate on conditioners for your hair. Many patients like to use a brand that has a shampoo and a conditioner. So, for example, we found the ingredients in that Pantene Pro-V Truly Relaxed Hair shampoo. They have a companion moisturizing conditioner, and it has cationic surfactants and polymers that soften and detangle the hair, and that's for straightened hair. For natural hair, there's a product called the Mame Choice Green Tea and Carrot Conditioning Mask. It has ingredients that hydrate and moisturize the hair. It also provides more slip so that when you comb out the hair, the comb glides through the hair more easily. Conditioning is critically important and beneficial during this particular time. There are leave-in conditioners that contain both water-soluble and water-insoluble silicones. Silicones can help reduce frizz and add to smoothness and shine of the hair. Now, the problem with the water-insoluble ones is they can build up. But, for example, there's a Cream of Nature Argan Oil Strength and Shine leave-in conditioner that has both insoluble and soluble silicones, as well as cationic surfactants. So that's a great example of a leave-in conditioner that will help moisturize and coat your hair, decrease the breakage. You can leave it in. You don't have to worry about applying heat. And this is really the perfect time.
I would agree with you, too. And I think the perfect time also for not only the women, but the children, too, because we're, having such an epidemic of hair loss from hair care practices. So I think, as you're saying, to use the products and to just get our hair back to growing naturally, it's going to be a great time. Hair is going to be longer. I mean, nature is so much more beautiful now with no cars on the road. I don't know about you, but the birds are singing. I have to close my door because it's so loud, and everything is blooming. But the other thing is, you mentioned in the article carcinogenic products, or some of them weren't proven. Could you discuss those a little, or what should people avoid?
So many patients I have found over the last 5 to 10 years are very, very interested in ingredients that could potentially be cancer-causing or can disrupt our hormones, and they will often seek out products that are, for example, paraffin-free, petroleum-free, preservative-free. So those are some of the buzzwords, I should say. And I think that for those that are carcinogenic, we can't say for sure if they are or not. I think a great deal of research still needs to be done. Parabens, as you know, are preservatives. They've gotten lots of criticism because of a possible link to breast cancer. There have been studies that have demonstrated weak estrogenic activity, and they've also been demonstrated in some studies to be endocrine disruptors and perhaps carcinogenic, as I said. So there are patients who are going to look at the list of ingredients, and if they do see parabens, they're going to pass by that particular product. In addition, often manufacturers will have right there on the label, for example, paraben-free, so that there's no question in the patient's mind of whether, this could present a problem. In addition, there's some controversy regarding mineral oil, for example, or tetrasodium EDTA. Again, I think the jury is still out. There are a whole host of products that do not contain those particular ingredients. So I think our patients have to have choices.
Okay, thank you for that clarification. So one other thing, a lot of dermatologists treat seborrheic dermatitis and hair of African descent, sometimes confuse seborrhea with just the gels that are left on the scalp. But one of the things I would like dermatologists to do is figure out a way, and most of us do this, but to be able to advise patients on how to counteract the harshness of some of the shampoos that we use for seborrheic dermatitis, such as ketoconazole shampoo. Could you discuss that in terms of the products?
Oh, I'd be very happy to. So I have a couple of comments in regard to seborrheic dermatitis. The first one is that there are a whole host of topical corticosteroids in different formulations that are highly effective for the treatment of seborrheic dermatitis in African American patients. So, for example, there is a prescription oil treatment that can be applied to the scalp overnight, and that 8-hour contact time can be very beneficial in treating seborrheic dermatitis. It also has the added benefit of the oil coating the hair and, again, decreasing the breakage of the hair. So we can add that to our therapeutic armamentarium in this particular patient population. There are a host of mild, mid, and super potent topical corticosteroids in cream and ointment formulations that also can be used quite effectively for the treatment of seborrheic dermatitis. So one does not necessarily have to rely on shampoos. Now, when it comes to shampoos like ketoconazole, like cyclopirox, what I suggest to my patients is that they apply the shampoo directly to the scalp with a 4 to 5 minute contact time, and then rinse the shampoo out of the scalp, followed by the use of a conditioning shampoo to actually shampoo their strands of hair. That way, they're minimizing the contact time with the prescription shampoo, which tends to dry the hair. So that's a pearl that I think has served patients very well. The other issue we need to discuss is the frequency of shampooing. As you know, many of our patients of African descent will shampoo their hair once every 2 weeks. So the recommendation of using a prescription shampoo every day or every other day is really not going to be satisfactory for our patient population. So that's one of the reasons why I discussed at the top using topical corticosteroids.
Mm-hmm. So I do the same, actually, too. And one of the things I have found in diagnosing, particularly with the residents and diagnosing seborrheic dermatitis and ask people of African descent, is that they'll ask the patient if they have dry scalp, and the patient will say no. But then you ask the patient, do they oil their scalp? And they'll say yes. And why do you oil it? Because it flakes, you know. So it's a way of diagnosing seborrheic dermatitis, you know, because in the culture, sometimes dry scalp is seen, or dandruff, you know, and that's a word you tend not to use, is seen as dirty, or if there's something wrong with them. But I absolutely do exactly what you're saying. I do that. I follow those guidelines too.
What I have found over the last, 10 years or so, especially with the popularity of braids, extensions, weaves, is that patients tend to shampoo less frequently. And that's a conversation that I think is very important to have with our patients. Although I prefer shampooing once weekly, I will accept once every 2 weeks, assuming the patient isn't having moderate to severe seborrheic dermatitis. But having that conversation with the patient about frequency of shampooing, I think, is very important.
Yes, and that frequency, I'm with the healthcare workers and first responders with COVID-19. Many of them are, coming home, they wash hair, body, clothes as soon, they undress at the door to their house and just walk right into the shower. And this is different for people of African descent. Now, most of them are people that haven't had time they haven't called to ask about it or had time to really deal with it. They're just trying to stay safe. But I think some of the suggestions you made before, like removing synthetic hair and just, because they're going to have to wash their hair every day, I imagine, after being at the hospital. Yeah. Any other suggestions for them?
Well, so I think rinsing the hair with water, not necessarily doing a full shampoo every day, could be helpful. Putting in a leave-in conditioner and reapplying the leave-in conditioner every day, I think, can really help combat potential dryness they can experience. The final thing is oftentimes our hair can be very thick and very tightly coiled. And I would like for the first responders to be able to dry their hair so it doesn't stay damp, throughout the week, because I don't think that's healthy and can contribute to some infections.
Very good point. Yes. And are there any other things that you want to add that you really want people to hear?
So one of the things we all, even though I have many patients of African descent, as do you, there's such a variety of hair care products on the market. And that's one of the reasons why I wanted to write this article, so that dermatologists and primary care doctors will have something to refer to. And I think having that, in your drawer you can pull out can be very, very useful. I think it's also important to have a conversation with your patient and say, I want you to know that although my hair is very different than yours and I might care for it differently, I learned a lot because I'm interested and I care, and I want to be able to advise you. And I think talking about differences can really make put the patient at ease and make them more comfortable, and hence able to hear and accept your recommendations.
And that concludes episode 60 of Derm Weekly. Derm Weekly is produced by MDedge editors Elizabeth Meshkati and Melissa Sears. The peer-to-peer portion of the show is produced by Melissa Sears and hosted this week by Dr. Lynn McKinley-Grant. Her guest in this episode was Dr. Susan Taylor. The news portion of Derm Weekly is produced by Elizabeth Meshkati. The guests this week were Dr. Michelle Tarbox and Dr. Luke Johnson. All MDedge podcasts are produced by MDedge and Medscape Editor-in-Chief, Dr. Ivan Aransky, as well as MDedge Executive Editors Kathy Skarbeck and Mary Ellen Schneider, as well as Multimedia Editor Terry Rudd. Social media is produced by Kyla Clark. Dermatology Weekly is produced, edited, engineered by Tyler Mundak. For all of us here at MDedge, I'm Nick Andrews. You're listening to Dermatology Weekly.